Thank you very much for such nice introduction. First, I'd like to thank Dr. Gomez for inviting me to this meeting. He gave me the opportunity to be with you today and to discover such a beautiful country. You will notice that the title of my presentation has changed a bit. I was hoping to present you novel results, but unfortunately, the result was not as good as expected. So you will see further on what happened. So today I'm going to present, first of all, on the first trimester prediction of the great obstetrical syndromes. Prevention of those syndromes is now possible. Today, we'll talk about prevention of preeclampsia and IUGR using aspirin, heparin, calcium, and L-arginine. There are also going to be talks about the prevention of preterm birth with progesterone and other prophylactic measures. It's one thing to predict, to prevent, it's one thing to prevent those syndromes, but who should receive the prophylactic measures? So can we predict women who will have those problems? Actually, most of the prediction is based on history. We are treating women with prior history of preeclampsia, preterm birth, IUGR. However, most of those cases occur in nulliparous women. Last year, the National Institute for Health and Clinical Excellence in the UK recommend that women at high risk for preeclampsia should be advised to take 75 milligrams of aspirin daily from 12 weeks until birth. How do they identify those high-risk women? With prior history of preeclampsia or chronic hypertension, and with moderate risk factor, including first pregnancy, BMI over 35, family history of preeclampsia, multiple pregnancy. However, using those criteria, we would treat more than 25% of the women with aspirin. So, in order to prevent the great obstetrical syndrome, we need to identify women that require treatment. And early prediction is the key. Today, I will discuss a bit about the controversies regarding the optimal combination of marker or factor used to identify women at high risk, and about the use of first trimester uterine artery Doppler for prediction of preeclampsia. I will give you a short presentation on how 3D ultrasound could potentially be helpful in that prediction as well. First, let's talk about prediction of preeclampsia. We all know about the placental origins of preeclampsia in most cases, and mainly the most severe cases. More than four decades ago, Rosen published that in normal pregnancy, the uterine spiral arteries were transformed, losing all of their thick and muscular wall that was found in women with preeclampsia. Recently, a systematic review demonstrated that in normal pregnancy, most of uterine spiral arteries were transformed, while most of the uterine spiral arteries in preeclamptic women were not transformed. Transformation of uterine spiral arteries occur between 8 and 16 weeks of gestation. It is believed that the trophoblast invasion into the myometrium occur at that time and then invade the spiral arteries that lose all of their muscular layers. So we believe that there's first trimester biomarkers that can detect and predict defective placentation using maternal serum markers and uterine artery Doppler. Dr. Zong published a very nice review of those markers 2 years ago. I will not go through all of these reviews, but mainly the main conclusion were that decreased PAPE, decreased PLGF, or PP13 were all good markers for preeclampsia when measured in the first trimester. However, the sensitivity of those markers were about 20%, the best marker being PLGF. However, the sensitivity increased quite a lot when we use as primary outcome early onset preeclampsia or preeclampsia combined with IUGR. A friend of mine recently published a prospective study and found in about 1,000 nulliparous women that PLGF was the only significant biomarkers for preeclampsia, severe preeclampsia and early onset preeclampsia. What about ultrasound biomarkers? First, let's look at the data regarding uterine artery Doppler. Uterine artery is very interesting because it is above the blood flow going to all uterine spiral arteries. And uterine artery PI has been correlated with incomplete transformation of uterine spiral arteries. On your left, you can see uterine artery Doppler of a normal patient, normal pregnant woman. While on your right, you can see the very low diastolic flow and the protodiastolic notches of a woman with severe preeclampsia. Dr. Baudu Singh, in a systematic review, reported that the use of uterine artery PI could lead to a 25 to 50% sensitivity for preeclampsia when used in the first trimester. And up to 90% of the cases of early onset preeclampsia could be predicted with the same tool. However, my friend in his prospective study did not found the same result. He showed that Doppler was not predictive of PE, severe PE, or early onset PE. Moreover, a systematic review suggests that first trimester PI had only a sensitivity of 25% for preeclampsia. Why there is such controversy? Why the sensitivity of first trimester uterine artery Doppler vary from 10 to 80% between the studies? I believe that the measure can be influenced by the gestational age. While most studies looked at uterine artery Doppler around 11 to 13 weeks, it is obvious that a Doppler performed too early, or if you did not adjust for gestational age during that period, you could lose the power of your tool. The measure is influenced by the site of assessment. This year, we compared the two ways that uterine artery Dopplers have been performed in the first trimester. I think that what we found is that the right way of performing first trimester uterine artery Doppler is by using the ascending branch of the uterine artery at the level of the internal cervical os. While if you try to do uterine artery Doppler using the crossover of uterine artery and the external iliac artery, like we do in the mid-trimester, your tool is completely useless. And unfortunately, this is the way my friend Dr. Dibert performed his study a few years ago. At least now we understand why there are very controversial results regarding uterine artery Doppler in the first trimester. Finally, the result is influenced by the definition of the outcome. Early and late onset preeclampsia are most likely, not completely, but most likely two different diseases. Dr. Romero's team lately published that in women with preterm preeclampsia, 75% of the women had placental lesion, while less than 1/3 of women with term preeclampsia have such findings. So when we look at the prediction of preeclampsia using uterine artery Doppler, we can see that the sensitivity is much higher for early onset or severe preeclampsia compared to the late onset or gestational age hypertension. So, my first conclusion is that the first trimester uterine artery Doppler is excellent to predict preeclampsia if it is performed at the level of internal cervical os. It is performed at or after 11 weeks of gestations, and if it is used for the prediction of early or severe preeclampsia. What about the combination of ultrasound and the serum markers? Unfortunately, there are insufficient number of studies that have been published so far. And the data from the Fetal Medicine Foundation are very strong. However, external validation is definitely required. And this is what we're doing right now in Canada. Because according to those data, we could be able to predict more than 90% of the preeclampsia cases with a specificity over 90% as well, which would be completely amazing. So what is unique about the FMF data? I think that there's some interesting point that we should note. First, in their model, they're including body mass index, which is in a growing population where body mass index is a strong strongly associated with preeclampsia in mainly in obese women. Moreover, just by using the mean arterial pressure in the first trimester, women in their cohort, they were able to detect 75% of the early cases of preeclampsia and 50% of the late onset preeclampsia. So just by using mean arterial blood pressure, according to that model, we should be able to predict most of the cases. So this is one thing that I think the most important thing that needs to be reproduced, because just by using BMI and mean arterial blood pressure, we should be able to predict most cases of preeclampsia. So my first conclusion regarding the prediction of preeclampsia is that uterine artery Doppler can predict about or more than 50% of the early onset preeclampsia. With combination of markers, we could probably reach up to 80 to 90% prediction. And finally, maternal history, mean arterial blood pressure, and BMI seem to be very important factors in the equation. Now, can we predict the other great obstetrical syndromes? According to Professor Brosen and Dr. Romero, all of the great obstetrical syndromes are associated with disorders of the placentation. Incomplete transformation of uterine spiral arteries have been reported in women with preeclampsia, but also in women with spontaneous preterm labor, preterm birth, PPROM, IUGR, and stillbirth. Let's take a look at the data regarding first trimester prediction of IUGR. There's not so many studies who looked at biomarkers, certain biomarkers for prediction of IUGR, but in most of them, there's evidence that when more than one markers, two and more markers are abnormal, the risk of IUGR is higher. Uterine artery Dopplers is not as effective for the prediction of IUGR than it is for preeclampsia. While IUGR can be related to a placental disease, it is not necessarily related to a disease of implantation or abnormal transformation of uterine spiral arteries. So the prediction of IUGR in the first trimester is difficult because of the heterogeneity of IUGR. And uterine artery PI is not as effective. Maybe serum biomarkers will be helpful, but so far they're not. And in fact, they're not for clinical use. Now, my data that I was, from which I was expecting a great result, can 3D ultrasound contribute to the prediction of IUGR and preeclampsia? First, several authors have thought about looking at the placental volume using 3D ultrasound in the first trimester. Using 3D ultrasound, we can easily get an acquisition of the placenta in the first trimester, and using the vocal software, evaluate the volume of the placenta. And 4 years ago, data from Dr. Rizzo were giving us great hopes. He found that women with preeclampsia have a higher PI in the uterine artery, but also they had much smaller placenta volume. And by combining those, they were able to predict up to 95% of the preeclampsia cases. Unfortunately, subsequent study did not found such result, and my very recent study did not find the same result as well. So 3D of the placenta, I don't think is going to be very helpful for for prediction of preeclampsia. However, in a large cohort study from UK, including more than 3,000 women, they found that the placenta volume at 11 in the first trimester was related to the birth weight. So women with small placenta had more chance to have a baby with a small gestational age, and women with large placenta in the first trimester were more likely to have large baby at birth. However, as you can see, there was an important overlap between the volume of all cases, and placental volume is not useful in clinic. We looked also at the placental vasculature, which by using the vascularization indices from the 3D ultrasound, we can evaluate the blood flow, the percentage of blood into the placenta in the first trimester, and hopefully predict which placenta defective placentation. Again, there was preliminary data that were very interesting, showing that most cases of IUGR had a very low blood flow in the placenta. However, again, subsequent study did not show the same results. Then, therefore, I believe that there's still one hope that 3D ultrasound can be useful in the prediction of preeclampsia or IUGR. It's by looking at the myometrial vascularization under the placenta. Since we're trying to detect women with incomplete transformation of uterine spiral arteries, it would make more sense to look not at the vasculature into the placenta, but under the placenta into the myometrium, where the defect has been showed. So far, there's only one study who compared the measurement of subplacental vasculature and the risk of adverse pregnancy outcomes. And what they found is that myometrium vascularization index done by 3D ultrasound would be probably the best marker for prediction of preeclampsia. But those results need to be confirmed. So my conclusion number 2. IUGR is difficult to predict in the first trimester. 3D of the placenta has very few value, unfortunately, but maybe the 3D ultrasound of the subplacental region could have some potential value. Now, what about the prediction of spontaneous preterm birth? Mid-trimester cervical length has been shown to be a strong predictor of preterm birth in several studies. And vaginal progesterone is a clear and efficient drug to prevent preterm birth in a woman with short cervical length. Could we measure the cervix in the first trimester? Again, according to Professor Nicolaides in the UK, it seems that this is possible. Looking at the recent paper, it has been measuring the cervix in the first trimester is a bit tricky. You need to identify the endocervical part of what you are seeing, and not measuring the isthmus part of the cervix. This is the tricky part. However, According to their data, it is reproducible. And what they found is all women who had preterm birth before 34 weeks had a cervical length under the 50th percentile in the first trimester. It means that cervical length in the first trimester could be considered as in the prediction of preterm birth. However, I don't know yet how we're going to use it. Are we going to start vaginal progesterone as early as the first trimester? I don't think so. However, a finding of short cervical length in the first trimester could help us to identify women earlier in pregnancy and maybe perform the mid-trimester evaluation of the cervical length a bit earlier in pregnancy, maybe around 16 to 18 weeks, compared to 20 to 22 weeks, how it is done in several countries right now. So, early preeclampsia can be predicted in the first trimester, combining uterine artery Doppler, mean arterial blood pressure, BMI, and serum markers. Other syndromes are less likely to be predicted using the same tools, but first trimester 3D ultrasound, the subplacental myometrium, and cervical length are under investigation with promising results so far. So thank you very much for your attention.